And so that's kind of a good piece there. And certainly the developmental stage of the survivor. And again, that's much more to do with the psychological impact, in that when a child experiences a trauma, and I know that some of you may have heard Dr. Aldifer earlier this morning talking about the trauma associated with cancer on every family member, developmental stage of the survivor and the family really do come into play. So, what kinds of things can be impacted by therapy? Certainly growth and development. And growth and development are probably the single most basic piece of having a child. We want to see them grow and develop. I mean, it's a very basic building block to what we hope and dream that they will be someday. And that's not just talking about linear growth. It's talking about intellectual and cognitive functioning and sexual maturation. Certainly vital organ function, the heart, the lungs, the kidneys, reproduction. Will they be able to have children someday? Will those children be healthy? Will those children, our grandchildren, be at any increased risk of problems because of chemotherapy or radiation my child received? And certainly one of the more feared, and thankfully not one of the very high problems, which is the development of second tumors, which can be both benign and malignant. And again, everybody is not at the same risk. Just because the child had cancer does not mean they're at absolutely a risk for having second cancers. And certainly psychosocial adjustment. Now, I know that you've heard about this today, and I know that you probably have heard, some of you, about the fertility piece. So I'm going to not hang heavily on those two areas and really focus on the ones that I probably deal with on an everyday basis, which are the endocrine system, neurocognitive functioning, cardiac, and again, I'm just going to briefly touch on fertility. So when we look at the endocrine system, the areas that we're going to talk a little bit about is the hypothalamic pituitary axis, which is the brain, the gonads, so testicles and ovaries, the thyroid gland, and the adrenals. So again, you probably saw this slide this morning if you were in Dr. Ginsburg's talk. So basically, the hypothalamic pituitary axis is, the hypothalamus is the master gland of the body, hypothalamus and the pituitary gland, which sit in the brain. They basically tell every other gland in the body what to do. Turn on, turn off, secrete more, don't secrete any. And so you could understand that if a child had high-dose radiation or surgery that affected that area, other organs in the body would be affected. And in the case of radiation directly to either the abdomen or the pelvis, in the case of a boy, those organs might be affected if by treatment directly. So this is a picture from a book that's really 100 years old. I think the book was published in 1930. But again, it's a perfect illustration. These are the Franklin twins, identical twin little girls, one of which developed medulloblastoma, which is a kind of brain tumor. And with the medulloblastoma, the girl on our right here was treated with whole brain radiation and then spinal radiation. And because of that, her growth hormone was affected again, because we have radiation to that pituitary gland. She had radiation to her whole spine. And so what we know is that when you give radiation to an entire spine to a young child, that spine doesn't grow as much as it would have. So that accounts for her being a little bit shorter, or even proportionately, that her legs are longer than the trunk of her body. She has a shortened trunk. And so this is an illustration that in identical twins, when one gets treated for cancer, chemotherapy, and radiation, there are going to be impacts on her physical need. So one of the most important things to look at with children, one of the simplest things to do, is a growth chart, is measuring your child and having your child weigh. Again, that shouldn't be your responsibility. That should be our responsibility when they come to see us, because again, this is one of those things that the sooner we intervene, the better things can be. So this is a child who had radiation and chemotherapy, and the radiation was to her brain. And what happened was, right after she finished chemotherapy, we began to see that she really wasn't growing. She was gaining weight, but she wasn't growing. And what we did was we tested her, and as it turned out, her thyroid gland wasn't working well as her pituitary gland. So we needed to replace her thyroid hormone, and then we gave her growth hormone. And then she began to go back up, and actually made it back up onto a growth curve. Just take a quick look here, because I know that we're
I have a question about that.
Sure,
though.
go ahead.
I was always told that that came into question with our daughter, that when they stopped therapy, we were told that if you gave growth hormone within that 5-year window, that there could be a possibility that you could, I guess, jumpstart any cancer blasts that might be left behind. And that's a choice you make when you start it. And so, is that true? Because I mean, we made the decision, because I'm thinking survivorship. I mean, she's going to be lucky if she hits 5 feet.
Okay.
And so the doctor said to us, you know, basically, there's a lot of 5-foot women out there. It's not the end of the world, but, you know, relapse for her would be dramatic. And
Okay.
so choice.
Right. So again, generally, we don't treat anyone with growth hormone until they're 2 years disease-free, regardless of whether it's leukemia, brain tumor, whatever it is. There have been a number of studies done nationwide that look at children who've had leukemia and children who've had brain tumors who then get growth hormone. There is no increased risk of recurrence or relapse in the two groups. They had a control group and they had a study group. So did children recur? Yes. But in both groups, they recurred at the same rate. It wasn't that one was higher than the other. I don't understand, you know, I don't know your daughter's individual situation.
I just you were saying you growth hormone. I was thinking.
Well, and generally 2 years disease-free. Now, sometimes unfortunate things happen, a couple of them. One is that if a child is diagnosed right in the time of when they're going through their pubertal growth spurt, and by the time you're finished with therapy, 2 years is done, growth plates are fused, there is nothing to do. And that's just unfortunate that it fell out that way. Many families choose not to do growth hormone because growth hormone is a hormone and people feel, and that's fine too. But again, we like to make sure that families have all the information they need and then they can go home and kind of sit together, put their heads together and make some decisions based on what works right for your family. In general, girls tend to be pursued less than boys with growth hormone because I think that I don't want to be, but from a societal perspective, a girl can be cute and shorter, but a boy really can't be that short. I mean, this is something that I hear repeatedly. But again, it's a very individual decision. What we do is we provide the information and we would do a full evaluation with an endocrinologist and then present you with what should be done. And then you guys would make the decision. And no one would pressure you either way.
Yeah, I don't think it's so much. I was in the impression that if we gave it to her under that 5-year, that if there was any cancer blast left, that they had to be found that could jumpstart them. And that's the only thing we've ever been told. So it's interesting that you just said that because I'm like, we never were told
You treated a child?
We're treated a child now, but she's only 13 months out from treatment.
Okay. Well, in about 9 months, she should see an endocrinologist.
Shared disease. Yeah.
Okay, good. All right, so you're doing all the right things.
Mm-hmm.
Again, when we look at ovarian dysfunction, there are a couple ways that the ovaries won't work. One is if radiation is delivered directly to the abdomen and pelvis. Now, there aren't that many situations where that happens, really. Bone marrow transplant, where total body radiation is delivered, certainly that would include the ovaries and the testes. In a situation where a girl has a pelvic tumor of some sort and needs radiation to the pelvis. But surprisingly, chemotherapy, it takes a lot of chemotherapy to damage the ovary from doing what it's supposed to do. The interesting thing between the ovary and the testes is it takes a lot of therapy to destroy the ovary, but when it does, it destroys the whole thing. And for males, it's divided into 2 different areas, and we'll go on to males in a second. So, girls, depending on their age, can receive 400 to 1200 centigrade. Now, do you guys know that measure of radiation? Because I'm sitting here talking about it, and I'm worried that I think everyone who's gotten radiation will say yes, and everyone whose child hasn't gotten radiation will say no. So if you feel like you need to know it, raise your hand and I'll explain that. But somewhere between 400 and 1200 centigrade will cause ovarian dysfunction, and that all depends on the age of the child. So a prepubertal girl who gets under 1200, most likely, if it wasn't total body radiation, will continue to have ovarian function for a period of time. If it's a girl who's 18 and she gets 400, her ovaries may stop to work. And that really is in relation to the number of eggs that are in the ovum. When you are born, you already have started to lose eggs if you're a woman. The most eggs that will ever be in your ovaries is when you're 6 months in utero. So from that point on, it's all downhill. So you can see that as we grow, we're losing thousands and thousands of eggs. So if you get treated at a point where you've already lost hundreds of thousands of eggs, your ovaries are going to stop working sooner as opposed to later. That's where the age-related comes in. But girls can get a lot of chemotherapy and still function, to go through puberty, and many times still have babies. We worry about girls who get a lot of chemotherapy and still have ovarian function. So now we're involved in a number of studies where we are trying to preserve eggs. And so if a young woman comes to us who got a lot of chemotherapy but still has normal function, normal ovarian function, we stimulate her ovaries to take a look at how much she has left. Is the tank half full? And we will actually do egg retrieval if the young woman would like to do that. Otherwise, we really encourage having babies at 4:30 because our concern is that we're going to experience a premature ovarian failure. And understand, after we're done, I'm going to allow time for you to say, my daughter had this or my son had that, and so that we can, if you want to have a little bit more specific information. So now in young men or in boys, it's two categories. The two categories are, one are the germ cells, which produce sperm, and one are the Leydig cells, which produce testosterone. The germ cells are very, very, very sensitive. It takes a very little bit of radiation to destroy sperm-producing cells, and it doesn't take a lot of radiation either. So let's take Cytoxan, for instance, or cyclophosphamide. That's one drug that if your child received, one of the issues might be gonadal function, might be a problem in the future. For a boy, if he gets about 10 grams of that, there's a 50-50 chance that he will be infertile. Take a girl the same age, 10 grams, doesn't do anything. It would take more like 30 grams in a girl. So you can see that the germ cells are very, very sensitive. That's the bad news. The good news is the Leydig cells, the cells that produce testosterone, which are going to make a boy a man, are very resistant, both to radiation and to chemotherapy. And so we less likely have to replace hormones for boys. We more often have to replace that hormone for a girl. And so again, it would take doses of greater than 2,400 of radiation to cause a boy to start having problems producing testosterone. So again, there's the germ cells, and there are the cells that produce testosterone, and we observe boys, we look at the therapy they receive, and then we determine whether we need to worry about that in any particular child. So, the next probably biggest question that I think parents and survivors alike have is, how will my child learn? Will their learning be impacted? And in general, for the majority of patients who do not get therapy to the central nervous system, the answer is that although you may see a short period change, where while they're on therapy they may not have a lot of energy to do their schoolwork, or because they're dealing with the crisis of cancer and they might be emotionally distressed, they might not be able to focus on learning, in general, those kids all go on to being okay in the end. Children who receive therapy directly to the central nervous system, it really does depend on the age at which they were treated and the therapy that they received. Whether they got intrathecal medication, which again is medication that gets delivered directly into the central nervous system, and whether or not they receive radiation to the central nervous system. So in general, the diagnoses that hold the highest risk for having cognitive difficulties 5, 10 years later would be children who have been diagnosed with a brain tumor, or children who have a disease that then have central nervous system involvement, like leukemia, that then is in the central nervous system. The kind of effects that we see, again, are general learning disabilities. Rarely is it at the point where a child will carry a diagnosis of developmental delay. Most situations where that diagnosis is given, the child already had learning disabilities and developmental delay coming into treatment, and then this kind of certainly didn't help the situation. But more of the issues are about attention and organizational deficits and slower processing speed. So a lot of times in survivorship, when we're talking to survivors, it's very important for us to make it clear it's not that a survivor is not smart. It's that how they have to learn and how they process the information we have to work on.